Hello, everyone, and welcome back to the podcast. Again, my name is Chuck Dowell. I will be the host of today's episode. Today is going to be part two regarding our distal radius fractures. If you listened last week to part one, we discussed a distal radius fracture in a young gentleman that we performed a hematoma block on. Today is going to be part two, where we're going to briefly discuss kind of our younger patients, our pediatric patients with these distal radius fractures, and some thought processes behind this. Again, today's presentation will be a video presentation, so you can log on to the YouTube channel and see the x-rays and the images that we discuss during the presentation itself. So if you're logged on or looking, here's an x-ray of a patient that came in. So this is a 6-year-old female who came and saw me in clinic. 2 days prior, she was climbing down the ladder of her bunk beds and she fell backwards. She landed onto her left wrist. She had some pain at that time. Mom states that she just isn't using the wrist as much. She's cradling the wrist, kind of refusing to do some activities with it. She gave it a few days to try to see if it would get better, and unfortunately it was not improving. So she brought her to the orthopedic urgent care 2 days later for evaluation of the wrist. On examination, there was some tenderness to palpation diffusely throughout the distal radius area. The tenderness was mainly within the distal third of the radius, extending into the metadiaphyseal junction and distal area. No evidence of angulation was noted on the examination. Some mild diffuse edema was noted throughout the area as well. She was able to wiggle her fingers distally. X-rays were performed, which you can see on the screen now. These x-rays included an AP of the wrist and forearm, a oblique and a lateral view. You can see on this AP view, this is a 7-year-old, so she is skeletally immature, and it's faint, but you can see that there is a fracture line directly through here at this kind of metadiaphyseal junction and the distal third of the radius. Again, if we go to our oblique view here, you can see this fracture line as well, and also start to see some slight angulation noted. And then when we go to our lateral view, this is much more apparent. So sometimes hard to interpret with these lateral views as far as the overlap. Our ulna dorsal cortex is here. Our ulna volar cortex is here. Our radial dorsal cortex is here. And then our radial volar cortex is here. So you can see there is a fracture through that kind of metadiaphyseal junction at the distal radius area. There is some evidence of dorsal angulation within that fracture. So a couple things to think about when we talk about fractures in young patients, especially pediatric patients. We know that distal radius fractures or forearm fractures account for approximately 40% of all pediatric long bone fractures, and distal radius fractures are the most common site of all pediatric forearm fractures. They generally occur on a fall on an outstretched hand with the wrist in an extended position. Some of the patients will come in like this. It'll be these unicortical or bicortical fractures, the so-called torus or buckle type fractures. The patients oftentimes won't complain of significant symptoms. There won't be significant deformity noted. The peak incidences do occur in our younger patients. So our girls typically between 10 and 12 years of age, and our gentlemen, our boys, between 12 to 14 years of age. Most commonly, they happen in children under the age of 16. Now, when we're evaluating these distal radius fractures, especially in our younger patients, these can be treated slightly different than our older patients because they do have what we call remodeling potential. They have continued growth throughout this bone, and as they grow throughout the bone will be able to straighten itself back out. So there are some acceptable degrees of angulation with these fractures in these younger patients. We know that this distal radial physis, so the growth plate within the distal radius here that you can see on the image itself, contributes to 75% of the growth of the radius itself. It contributes to 40% of the entire upper extremity growth, and typically this growth is at a rate of 5.25 millimeters per year. Most commonly, when we do see these fractures, they are at this metaphyseal junction or fracture area distally, and that's typically where these occur, such as did occur in this patient. So again, 62% will occur within this distal metaphysis or metadiaphyseal area. 20% will occur within the diaphysis itself. And then the other 18% can occur throughout the forearm. We always want to evaluate anytime we see these distal radius fractures, especially these more proximal and diaphyseal fractures, the proximal radial carpal and ulnar junction, to make sure there's not evidence of a montasia or a Galeazzi type fracture in these patients. So again, the workup typically involves x-rays. In this patient, you can see these x-rays did show some evidence of some slight dorsal angulation. Now, knowing that this patient is younger, 7 years old, and has a lot of remodeling potential and growth plate potential throughout this area, does kind of change or distinguish the way that we treat this fracture. So you can see on the screen now, this is kind of our thought process regarding the remodeling potential in these patients and the acceptable degrees of angulation. Now, one thing to keep in mind, generally we know that fractures that or deformities that are in the plane of the joint motion are typically more acceptable, and distal deformities, anything closer to that distal physis, we can typically accept more angulation than these mid-shaft fractures, because again, a lot of the growth is going to come through this distal physeal area, and this is a lot of the remodeling potential will come from. So this one doesn't necessarily apply specifically to our patient, but in general, patients 10 years and younger have quite a bit of remodeling potential. So you could see acceptable angulations in 10 years and younger on the AP view are approximately about 15 degrees, and also on the lateral view, 15 degrees of angulation. In 5 years and younger, we can accept up to 20 degrees of angulation. Anybody over the age of 10, we want less than 10 degrees of angulation, because we know that they're getting closer to reaching skeletal maturity, and these degrees of angulation can cause possible rotational issues. So again, any fracture that heals with a final angulation or degree of angulations of more than 10 degrees, especially in this diaphyseal area, can block approximately 20 to 30 degrees of rotation, including supination, pronation activities. So anybody over the age of 10, we definitely want less than 10 degrees of angulation when we're measuring. Anybody under the age of 10, we can accept 15 degrees or so. Again, this is in these mid-shaft fractures. In these proximal third fractures, again, the growth potential throughout that area is less. And so again, less than 10 degrees of angulation proximally, and ideally anatomic reduction, anybody over the age of 10. Again, a little bit of another kind of diagram here. Excuse me, let me adjust this slightly. When we're talking about angulations of fracture. So again, this diagram applies to these mid-shaft diaphyseal fractures. These are acceptable angulations through these distal radius and distal fractures as well, but we can accept slightly more angulation, as mentioned, because of the growth potential throughout this area. So again, we know 5 and younger, up to 20 degrees of angulation, 5 to 9 years old, up to 15 degrees of angulation, and then anybody over the age of 10, again, ideally less than 10 degrees of angulation. And some of the literature here, kind of going back, there's multiple studies that have, shown the ability of remodeling potential regarding these patients themselves. So in my patient that did have this distal radius fracture, these were the initial x-rays when they came and saw me. So you can see there's minimal change, but you can see the angulation within the fracture itself. We did immobilize this patient, so they were placed into a short arm cast at the time. We know that these fractures, especially these kind of unicortical buccal type fractures, typically don't swell quite a bit. And so oftentimes, even when I'm seeing these acutely, especially these buccal fractures, we can typically cast these right away and the patients will do well. I would say the more proximal the fractures are, the older the patient is, the more we're trying to hold reduction, we may go to a long arm cast in some of these patients. But this patient we placed into a short arm cast. We did try to mold that cast again again, to try to prevent any further dorsal angulation of the fracture. So after the cast was applied, I did try to perform a little bit of volar molding as well as an interosseous mold, trying to kind of compress that fracture together to hold it in a good position. Approximately 2 weeks later, this is the patient back into the hand specialist's office. You can see the short arm cast is in place. You can see that the mold allowed for that fracture to stay in a good position. And these are x-rays showing that the fracture looks like it's in a stable position. And then again, 1 month after the fracture, you can see here that the fracture remained in a stable position. There was good cortical, healing in this area. And again, you could see a lot of good cortical healing on all 4 cortices here, remaining this in a stable position. So in a 7-year-old patient, typically 3 to 4 weeks in a cast, followed by 2 to 3 weeks in a splint and or a brace that they can remove, and then they can progress back to activities and usually full healing. Again, the healing potential in younger patients is a little bit quicker. As we get older, our ability to remodel and our bone, kind of healing potential gets a little bit less. And so this will change kind of, how we treat these fractures. Again, a couple kind of examples of some other patients. This was a slightly older patient. So this is another gentleman that I saw, a 13-year-old patient who was playing hockey. He collided with someone and immediately had pain within his wrist area. These are the initial x-rays upon presentation. You can see he has, again, this metaphyseal distal radius fracture with these cortical bucklings noting on the AP view. A little bit of an ulnar styloid fracture noted there as well. He's 13, so he's over that 10-year age, so our acceptable degrees of angulation is a little bit less. So again, ideally we want this within 10 degrees of angulation. When I measured this in clinic, this was less than 10 degrees. So we discussed with the patient as well as his family members that we can place him in a cast, again, mold the cast to try to get a good volar mold. Sometimes I can even, especially in these acute fractures, do a little bit of a reduction in the cast itself. So oftentimes what I'll have the cast techs do is I'll have them put the cast on, leave it pretty wet. In these casts, especially an older patient, we'll do a monster cast or a bit of a long arm cast. And then as the cast is drying, I'll try to reduce the fracture a little bit and mold that fracture into a good position to try to prevent further loss of deformity and maybe even correct some of the loss of deformity that was there. About 10 days later, he came back and saw our hand specialist. You could see it didn't get much improvement with the molding of the fracture, but is remaining in a stable position. Was able to get kind of a good mold on the cast there. And then kind of follow along x-rays. He was seen a few weeks after that to make sure that, kind of things remain stable and we're healing well. And you could see these x-rays would be approximately 3 weeks after I initially saw him. And his last x-rays upon discharge are here. And you can see there's good cortical kind of thickening here, excellent fracture healing seen. And you can see that fracture kind of remained in a stable position on those x-rays. And so he was in that cast for approximately 4 weeks, and then was placed into a Velcro brace for approximately 3 weeks. No contact or sports-related activities for approximately 6 weeks, is not to fall and have a re-injury to the area. So again, I hope this was kind of insightful. We do see these younger patients that come in with these distal radius fractures. Sometimes these are bicortical, and as they're through both of the cortex. Sometimes these are just buccal fractures where they're unicortical fractures. We can treat these slightly differently depending upon the age of the patient, their remodeling potential, their continued growth throughout that distal radius, their proximity to the radial physis and or the ulnar physis, depending on where the fracture is at. Again, always want to make sure we evaluate the joint above, so make sure there's no pain within the elbow area that could be consistent with a Galeazzi or Monteggia type fracture. And again, quick reminder here, just going over again, a Monteggia fracture would be a radial head dislocation. with an ulnar kind of mid-shaft or proximal fracture. And a Galeazzi fracture would be a distal radius fracture with an injury to the DRUJ, or distal radial ulnar joint. Again, Smith's and Barton fractures are discussed here as well, but when we're looking, that's kind of what we're looking for as far as fracture patterns. So again, we can treat these fractures a little bit differently, depending on how close they are to the growth plate and their remodeling potential. I hope this was helpful and insightful regarding, seeing these younger patients and potentially treating them. I think, again, oftentimes these don't tend to swell a lot, so you can cast these right away if you're in an orthopedic clinic. If you're not in an orthopedic clinic, an urgent care, or an ER, you can put these into a splint, either a sugar tongue type splint or just a volar splint, and allow them to follow up with orthopedics and get kind of definitive casting at that point. Thank you very much for listening, and have a good day.